Thank you very much. We will call our meeting to order. We do have a quorum. I will do the invocation. Father, we thank you for this day. We thank you for the many blessings that you bestowed upon us. We ask that you guide us as we go through our meeting. Give us wisdom as we make decisions that will affect our citizens of this county. In your name we pray. Amen. Before we get started, as far as a motion to approve the agenda, we have amended the agenda. Item J, which was the motion to enter into closed session. We will not need to go into closed session tonight. So again, we will be amending the agenda to eliminate that item. So again, may I get a motion to adopt the amended agenda?
Move to approve as amended.
Okay, and I guess that's second. All in favor? Aye. Thank you very much. Motion carried. Okay, at this point, we will start with our next agenda item, which will be a special presentation from the Modern Woodmen of America.
I like your mighty modern.
Your mighty.
Well, Chairman Mack, thank you. I appreciate this opportunity. I have Michael Herbert with me, which in this room, most of you really know, and you probably know me, Nancy Litton. But we're here with Modern Woodmen. What is that? It is a financial planning institution of which Michael is our financial advisor. So his day job is to help individuals with retirement, with insurance, with those sorts of things as a financial advisor and planner. Michael has me a part of his team because I am one of his customers. I have my retirement accounts with him. But Modern Woodmen has been designed to give a portion of the proceeds of all of their profits come back to the community. So we're here tonight because our chapters, we call our groups chapters, and we have 2 in this area. Our chapters identified the work of Cabarrus Health Alliance with one of our special projects of being a hometown hero. In this wonderful year of pandemic, we're in the midst of a campaign called 2020 Wonderful. And Cabarrus Health Alliance is our 2020 Wonderful hometown hero for Modern Woodmen. And we applaud you for the work you're doing. I would like to tell you that we've tried to connect our services with your work as many places as we can. So one of the things we did first was provide lunch for one of the clinics at the arena. And in case someone's taking note, I still have one opportunity for lunch. It happens sometime between now and October 31st. So I have today, as a part of the Hometown Hero, a small stipend to present to our chairman, a $100 stipend from Chapter 5311, and to our executive director, CEO, a $100 stipend from Chapter 16721, and a 2020 Wonderful pen for you all. Thank you. Now, I know we have a brief time to speak, but you might want to ask, what else could we do for you, or what else might you want to know about us? Michael, what's that thing we do where people raise money and then after they've raised money, what do we call that?
I ask you the same question. It's called our Magic Fund event.
Yes, that's what I'm talking about. And I know that the Cabarrus Public Health Interest from time to time does do fundraisers. So when we get to 2022, if you're planning something like, I don't know, a golf tournament, and you're looking for a way to sort of bolster those dollars, we may have an opportunity to work with you on a matching gift project. And Michael would certainly love to stick some little flyers and business cards in those bags that you might be getting. What did I not say, Michael?
Thank you. I will tell you on a personal note, for 5 years of my life, I worked professionally right on this spot. I worked for First Bank. And for those of you that remember the little tiny First Bank brick building here, I was a loan officer for First Bank for 12 years, 5 of which were right here on this little corner. So I feel like I'm back at home.
Yeah. So as a fraternal organization, we are happy to share with you some of our proceeds. Our job is to put those seeds back into the ground so that they can prosper and bring more for others. Thank you all. Appreciate it.
Thank you. Thank you very much.
We're gonna slide. Oh, thank you. Have a good meeting.
Thank you. Okay, our next agenda item would be the approval of our minutes. We do have the closed session minutes in the yellow folder in front of you. So I would ask you, I guess, before you have the opportunity to leave, you could go on and read those. And again, if there are any corrections or anything that you need to make, you can make those. But at this point, may I get a motion to accept the approval of to approve the minutes for the last meeting, May the 11th, and also the May the 11th closed session meeting notes? Can I get a motion to approve those?
I have a question.
Question?
So is there an option to approve the closed minutes and leave them open or leave them closed? To approve the minutes, but leave them open or leave them closed. So if it's closed minutes, then it's not open to review. If it's open minutes, then it's open to review, and there might be something on this that we would want to have closed.
They remain closed.
Yeah.
As closed
So our
as
closed minutes, they would make,
closed.
so we can close and open. So I wanted to make sure what we were doing was appropriate.
Yes, and that's why you have those in hard copy, so if you need to make any adjustments, you can note those in writing, because they are closed.
Yes.
Thank you.
And again, I would need those photos when you leave, so again, we can have those to basically put in our records, okay? So,
Then I would move to approve the May 11th regular meetings and the closed session meetings.
okay, may I get a second? Second. All in favor? All right. Again, like I said, again, have the opportunity to look at those and take care of those. Okay. All right, our next agenda item would be to go into our reports, and Sue Yates will be up next.
Okay. Chapter 15.
I bring to the meeting's attention that Mr. Kincaid is late.
Well, thank you very much. I almost fell on the floor, so we're off to a start. I apologize. I got tied up in traffic in Charlotte. You know, you can't get around Canalmas anymore because of city council, you know how they are. That's what they're thinking. I did want to come. I will have to scoot out just a little early. I got a 6 o'clock board meeting at City Hall, so I wasn't going to miss getting to talk to you guys.
Good evening, board members. I'm going to talk about our financial report. As we are at the end of May, we have one more month in our fiscal year. At the end of May, based on the summary report, we are in the green. Dental, of course, is still yellow. We're watching dental, recruiting dentists and other dental staff and making some changes there. If you'll go to the next report, this is the CHA report. It will show you at the end of the fiscal year, based on our current numbers, we would be making about $500,000. I do want to remind the board last fiscal year, we lost $705,000. So we've been diligently working this year to get the funding back in. We've been doing billing for our COVID vaccines as well as the testing that we did prior to the vaccines. And we are still waiting on our Medicaid cost settlement numbers to come in. So this does reflect our budgeted amount of $1.2 million. We have heard from the state, they're anticipating possibly giving us up to $2.4 million on the cost settlement, but we do not have final word from them as of today. So we are waiting on that. So I will bring final or close to final numbers to the board in August. On the next report is the variance report, and it compares where we are this year to where we were last year. Our biggest changes is last year we did not have COVID vaccine money. We did not have COVID vaccine expenses. And we did have the NCTN project prior to this year that we no longer have. And that is it. Are there any questions about the financial reports? Okay, thank you.
Right, next on our agenda is the equity coordinator introduction. So
He is over in the other room. I think nobody told him to come this way. This is his first board meeting.
Oh, okay.
Somebody grab him.
Here it comes.
What was that?
I think so part of this is my responsibility. This is Mr. Keon Lewis, the new equity coordinator, and we have been waiting a long time to get you in, and we're glad to have you, and take it away.
All right, well, good afternoon, everyone, and thank you for this opportunity. Thank you for allowing me to be a part of this great organization. I'm looking forward to being a significant contributor, to being a part of the advancement of the DEI committee, as well as what the proclamation this team is doing. I love the worthwhile mission of it, and I plan to be a vital asset in contributing to the success of this organization. So one of the things that I wanted to discuss with you was some of the current things I've had the opportunity to work on. Thus far, I've helped complete the DEI Inclusion Committee Charter. I've also helped to establish an employee feedback line. This will be a great opportunity for us to get positive feedback from our staff members, as well as address any issues that they may feel they need to discuss, and they can do it discreetly and without any type of repercussions. Another key aspect is I had an opportunity to establish key relationships with minority serving institutions as well as HBCUs. I wanted to help create a career pipeline with these great institutions and to help advance the recruitment aspects of CHA. Another good thing that I'm having the opportunity to work on is I'm responsible for the development of the coordination of the REC listening sessions. This is with Grace Equity Cabarrus, and it gives the staff members an opportunity to have good in-depth discussions, to talk about some of the current affairs that's going on, some of the things that they're dealing with internally, as well as any issues, any aspects of discussion they might have about equity. Also, in the future, I want to make sure I work diligently on the development of a health equity webpage. I think this will be a great opportunity to provide resources to the community and our shareholders to let them know the great things that we're doing as an organization, as well as make them aware of some of the things that's taking place locally as well as nationally. I would also like to conduct an organizational equity assessment. I would like to strive to create the development of an annual equity report. This report will give the community an opportunity to not only see the great things that we're doing, but will also be a key tool to keep us accountable of the future goals that we've set for ourselves as an organization. And lastly, I want to work diligently on the creation of an annual public health forum. I think this will be something that will be very formidable for the community. It will bring a lot of key resources to the community and give us an opportunity to be a key leader in having those key discussions to talk about some of the social determinants of health in our communities. Yes, sir.
So your last bullet item that you just mentioned, the annual Public Health Equity Conference.
Yes, sir.
Would that be a community-wide or broader or?
Broader. So we definitely want to incorporate community leaders as well as our organizations, but we want to make sure we're inviting people on a national scale as well.
Great. Fantastic.
Thank you. I appreciate it.
Go fast.
Thank you. Welcome.
Thank you.
Yeah, no.
Yes.
Thank you.
I'm going to deviate from the agenda just a little bit. Since Tom, you said you had to leave at 6, right?
Yes.
Okay, so at this point in time, I'm going to go along and kind of skip down to the announcements. And the announcement that we have at the present time, I do have an award that we would like to present to Mr. Kincaid for his years of service here at
Years?
Yes.
I should present
2012. 2012, I remember the day that we both came in together.
Yeah.
And for the service that you have given. And as a matter of fact, you served the first year as the board chairman. So again, we just want to thank you very much for the service that you
I
provided.
just dusted the seat out for you.
But again, we appreciate everything that
Thank
you've done,
you so
the
much.
contribution that you've made. And again, like I said again, you're still welcome to come over. I guess we have several committees and things that, we'd like to participate. Thank you very much.
And I'd just like to say to the board that it's been an absolute honor to work with such a great group of people. I've learned a lot of things in the health department, but the one I've learned the most, and I'll never forget, is PPEs. I'll take that with me forever. Personal protective equipment. It was awesome. And also just to see how the health department works through a crisis. And we actually got to see that last year, and this department did marvelous. I think it was heads above any other county. So thank you all so much for allowing me to be a part of this. I'll always be a part of this. So thank you and continue your hard work.
I just want to say, you have been an inspiration for me coming into this board and in general, in the leadership that you provide here in the community. You're really going to be missed here. And I just want to thank you so much for what you've done personally.
That's so kind. Thank you.
And also, this time, when you see here, I want to also present Dr. Bubwell, who is retiring at this point in time, and we do appreciate the time that you have served with us on the board. Thank you so much for your service. And again, from what I hear, it's not over. So we're still going to be looking for you to work with us on several committees. But again, thank you so much for the hard work and for just the information and just the knowledge that you've been able to provide for us as we're working on the board. So we appreciate that very much. And again, we look forward to working with you down the road in some of these committees. Okay?
I'll be here.
All right. Thank you.
If you're going to, and it's cropped in too much, you can by
Kevin, we're gonna
9
take a
of what
recess
that
and we'll resume
webcam
in
is
10
bringing
minutes.
into Microsoft Teams. So if you have a Teams room that you're joined to, and it's cropped in too much, you can
more, myself, school health and environmental health, and we will be done for the fiscal year. Before I get started, I wanted to introduce two key components of the team. I would not be standing here if it wasn't for them. Madeline Turner and Medjatu Kuyate. Madeline is our CDC PHAP. She is our population health specialist, our coordinator, and she has been keeping us aligned and on task. And then G is our epidemiologist. And so please look for great work coming from both of them from our strategic plan. They have some great ideas, innovative and really talented. So thank you guys for just all your effort. And this is a team effort, so please know the team effort. All right. Thank you. So under our first priority, use data to improve health, our team really owns this goals. We have 3 goals under here. Go to the next slide. Under goal 1, we have 4 objectives. One of them was to really ensure that we have public-facing data repository. 2 was to have a functional performance management page. That would be our fiscal year 22 plan. We would also have a SharePoint that is for internal staff. It's agency-wide. Everybody in the agency can access it. And then 2022, we would like to establish an interactive visualization tool using ArcGIS and Tableau software. Using that tool, we'll be able to depict the lay of the land of Cabarrus County and really pinpoint areas where we need to be able to go out and influence and improve health.
What data set will you use for that?
So
For the visualization tool?
We have different ones. So it's probably county level data, specifically broken up by zip code. And so we use some census tracking data. We are working with a regional team, and we are working with some members of the state to kind of get us Cabarrus County specific data, especially because a lot of our reports, we report out to the state, but they don't share that information back with us. And so we're using different tools to depict that. Just one of our accomplishments, we're proud to say that we are at 85.2% of scorecards that are complete with access with information. We have a few scorecards that have to wait to the end of their fiscal year to wrap up some of their data entry. But our main goal was to hit 80%, and we were glad to hit 85.2 as of 3 p.m. today. So thank you for that. We also wanted to share with you that we do have a web page. It is under the performance scorecards. These are interactive scorecards that you can use that will track data. I don't know if you remember a year ago in February, I came to the board and I asked that we move our performance management system to a results-based accountability framework. With doing so, over the past year, we've collected data, county-level data, and program-specific data. Our main initiative is to improve health, and so we're glad to say that that is live. Everybody can access it. We still have some data sets that we are updating, and I wish this visual looked a little bit better, but the screenshot does not do that justice, so please use that.
In the list view, the cogwheel icon will be located next to the Join or Create Team button, located at the bottom of the Teams list.
We have a list of objectives that we have decided to focus on. Our main thing is to provide a data equity plan. Basically, we realize that there is some discrepancy in how we collect data based on real data. What we call real data in our arena would be race, ethnicity, age, language, or location. And so we realized that sometimes when we got data sets that race and ethnicity were put in together, and that caused the discrepancy. So our pie chart would show 150 and not 100. So we're really focusing on making sure that we provide training for our staff, also to make sure that we have a full epidemiology plan, our data equity tools, and then make sure that our performance measures are associated with pillars of the proclamation. And so we have been working with a team, 2 interns, along with Keon has joined our team, Brooke Narby, which is CDC PHAP, Maddie, myself, and Meji have been working on data pillars, really to define data sets based off of the proclamation. So we've been working on that. of our accomplishments, we did have a clear impact super user training hosted in December 2020. We had about 15 super users, so there are 15 leads in order to update that data set that I showed you, the scorecard that has gone live. It updates in real time, so as things change, we can make changes and then we can therefore inform everyone else. We also have been able to use our Healthy Weight Oral Health and Tobacco Scorecard across all clinics to make strategic decisions, and we're pretty proud of that, just making sure that we're all on one page, collecting those 3 indicators. Under our second priority, we have 2 goals that we want to achieve. So our first one is to attend at least 2 diversity, equity, and inclusion trainings per year, along with our racial equity affairs listening sessions. The team realizes that being able to not only focus on the numbers, but focus on the qualitative data and what we get back from those trainings in order to inform how we do our processing and how we design some of our plans. Our next goal is to evaluate ways to prevent the public health crisis through data. And so, as I mentioned before, that data equity plan is really important. That framework, that real framework, we really want to make sure that the agency understands it, but also our community partners. And so we're working on developing that framework and being able to launch that by fiscal year 2022. We have some goals under goal 4 to sustain collaborative systems that address social determinants of health. Maddie Turner, our CDC PHAP, is really our champion in this sector. Next slide. We have 4 objectives that we would like to achieve, mainly having a social determinants of health and health equity training for staff in order to understand all components of health that are impacting us. To conduct an assessment of social determinants of health screening tools. So we do have a partnership with NC Care 360, but what we realize is that if we had a screening tool that addressed all of the social determinants of health, we can be better informed by the programs we implement and the partners we work with. The next part is having a population health program plan that details activities in order to monitor population health outcomes. When we talk about population health outcomes, our 2 biggest sets are our Healthy North Carolina 2030 and our Robert Wood Johnson County Health Rankings, and Maddie oversees those programs. Our last one is to do our social determinants of health and health equity challenge, which will be July 1st. We're really excited about that. That is a 12-month challenge, challenging agency staff to really hone in on understanding what social determinants of health are based off of their specific topic areas and their different sectors.
Well,
yes.
If you don't mind, I ask you questions. In that whole area of social determinants of health, there's a number of agencies within the county that focus on those kinds of issues and that are working on those and have their own sets of goals and priorities. Are you aligned with them, interacting with them, knowledgeable of what they're trying to do? Are they knowledgeable of what you're doing?
We are just at the beginning stages, and we will be working closely with Marcella and the work that she does with helping Cabarrus to be aligned. Essentially, we need to, first, our assessment is to provide that education for our staff to understand, and then to be able to turn the curve on those specific determinants of health is working with our collaborative partners and doing so. So we're in the beginning stages, understanding NC Care 360 alone and how we can use it as a referral service, ensuring that the school health team is going to be trained on that as well, and making sure that we're going to be able to use it across the agency. And so that's really our first point of contact.
In my efforts to try to be informed about these issues in a general sense, what I found is the nomenclature can get very confusing, and so the alignment of the use of terms and concepts that are behind those seems really important.
Yes.
And I think we can play an important coordinating role.
I definitely think so as well. And knowing that we have those 5 components of social determinants of health, one of our biggest things is as we're doing the equity challenge, Maddie will actually be reaching out to community partners that are working in that sector. So you will get an email coming from her pretty soon about how you can assess education and how that ties into the work that we do, or how we can talk about neighborhoods and access to care. All right, so we have 3 goals that we have highlighted under transform agency capacity, culture, and practices to achieve excellence. So 2 out of the 3 on the first goal have been completed. We did conduct a data series for staff. Maddie is working on the population health lunch and learns. And then on top of that, we'll be working with North Carolina Accreditation and FABS for staff to realize their roles that they play in order to achieve accreditation. And so what we have done is reassess all the standards and benchmarks, both for FAB and North Carolina, and say, what job function will that work with, and how do we get everyone aware of certain aspects of accreditation. These were the data series that we conducted across the agency. Why is data important? Data equity, RPA, how to use your data, Scorecard 101, and Public Health 3.0 and Population Health. If you would like access to those trainings, we can
What's
send
up,
them
guys?
to you.
In this
But
video,
everybody
I'm
in the
going to show you how to
agency
connect
completed that. And
OBS.
so we were super excited that it was
Subscribe
on our
to our
performance
channel. Let us
evaluation came around full circle, and that we
link
were able to
all of
really
that
have
in
staff engaged.
the web
Staff
form
really received
inside of
it
any
well and
software.
invited us to some of
So
their
whether you
huddles to describe some of the topics
and
that we
I
covered
can,
in
so
these
once I
trainings.
select that for the meeting to start.
Our next
what if you
one
want
is
to
to
play a
maintain a
video?
culture of quality improvement. And so basically, over the past 3 years, we've worked really hard in transforming our QI initiatives to be more data informed. So as you see on the interactive scorecards, what we are doing is we are associating them with turn the curve activities. So we'll be picking a specific population indicator,
OBS
a
has this
specific
new
performance
feature
measure
called
for departments or programs to pick to turn the curve on.
production software
Working
OBS.
from
This
end
also
to
works with
mean,
vMix.
and really being strategic about some of the points
Install
that we want to
one
make.
additional plugin
The next
into
one is
OBS
to
to maybe get
reassess our
your
performance
audio
management
monitoring
system.
system
It's
ready.
a
That's
quick
what we're
assessment
doing.
that goes on within
Countdown
our
timer.
agency and make sure that we've been able to move the needle in some of our performance
Plugins,
management
find
tools.
that. The audio monitor
Under goal 5, we have
Limited
2. Academic health department, which would bridge the gap between academia and public health practice. We do have a summer intern, Tyler Columbus, just joined us on Monday, and he is researching different innovative ways that we can actually bridge the gap between practice and education. And so we're building up on that. We're looking forward to having that. And then last but not least, our workforce development plan. I'm working with my favorite right here, Steve, and we are working to ensure that our workforce development plan meets staff standards and that we do have a succession plan that is focused on public health competencies and readiness.
Betty, when you say academic health department, could you expand on that?
I'm excited you asked. Okay, so with the academic health department, what we realized is that there is mutual agreements between academia and public health practice. And so it could be in the form of taking interns and having a professor of practice be at your entity. For instance, if you invite us over to the research campus more and we can teach. Or if we have any kind of collaboration with translational research, basically taking what research you have to influence our practice, or research that might be done over at the research campus to influence our practice, and having that shared mutual agreement. And so we're looking at different innovative ways to promote that, bridging the gap between practice and academia.
This concept, Mark, really works well with us partnering even more effectively with NCRC. How do we get, again, public health practitioners partnered with researchers and educators so that we are directing efforts towards improving the health of the community?
So you might want to make note of the fact that toward the latter part of the summer, I anticipate that we're going to have provosts and the research directors from all of the campuses that are represented here in Kannapolis at the NCRC. And see an opportunity for a discussion with them about how there can be partnership that goes beyond the folks that are sitting over here, but that reaches back into the home campuses to bring this to life in a stronger way.
We would absolutely love that. We've been, actually, we worked with UNCG with one of their grad classes on the proclamation, and we were able to use some of the assignments that they actually did for their final assignments and actually utilize them here at CHA. And so we've noticed that there is a tremendous gap in that we can actually increase our productivity by new minds, new, young, creative, and innovative minds, but also that we can share resources. Any questions?
Yeah, so will you get, I know we focus on racial and ethnic, cultural data. We get pretty robust economic data to be able to start foundations.
So, yes,
Yeah.
and this is a segue, so I will be back with Menchie, because one of the things that we realize is we do have a discrepancy in collecting data for Cabarrus County, and it's not just a little one, it's a huge discrepancy. Economic data, breaking things down, understanding things based on zip code or median income, we've been able to pull that from the census. But what we really want to understand is the health of our community. And in doing so, we know that there has to be some partnership down the line with Atrium, with data sharing, and being able to just really access data that you may be getting. Of course, HIPAA friendly. But what we realize is we don't have a lot of robust data for Cabarrus County. A lot of our data is from the state, especially comes down from a regional level. And so in order to disaggregate that data and say, hey, we really want to focus on Cabarrus County, it takes pulling teeth and going back to the source. And then what we also realize is that in order to collect that data, we have to ensure that everybody understands why they're collecting it. You know, you just can't fill in the box, check, and that messes up the data on our end, you know.
Yeah, because I mean, I got to see sort of the first pass. You heard about the data wall that's being built, and you ever get to see anything there? So I probably had to look at it. There's surprisingly less variation than you would think on outcomes. But again, it's an acute care system, so that doesn't really tell you what you need to know. If you come in and you survive an MI at the same level as everyone else, it doesn't tell you whether you had your MIs 10 years earlier or not. And it actually was surprisingly equal amongst African American and white populations, but the Latino population was lower pretty consistently. You know, you also wonder about they're typically under or uninsured, and you also look at some of the outpatient metrics, and those are where you get a gap.
Yes.
And that's a lot. If you live in that world, that's a lot more. You know, the entrance to the hospital is pretty. There's no more equity than EMTALA. You walk in, we don't ask you anything, we treat you the same.
Yeah.
And again, but that's acute care. Like I said, if you have an MI at 80 and survive it, that's a lot different than having an MI at 50 and survive it. And what are the differences and what led to that? So I think we're going to need to get that to actually not. The other thing is that was interesting is the perception of care was different than the actual outcomes.
Yeah.
So I actually think perception is frequently harder to change than the outcome, so that's a really interesting concept that we'll have to work with. So I don't think without having that third axis, we really can get the level of detail because my personal feeling from doing so a long time is the green is the color that drives much more of your outcomes than any of the other colors. So I'll just put that out there because most of preventive care and a lot of the things that keep you out of the acute care hospital is not accessible, depending on your socioeconomic status, independent of your race or ethnicity. So that's the piece we have to get that on, because that's where I think the hospital can make a much bigger investment.
and we talked with Dr. Coyle briefly about it. One of our biggest issues is making sure that we are able to have programs that deliver quality service, but our programs are data focused, that we're not just, shooting into the dark, that we actually have data informed programs that can assess the whole population. And so,
Yeah, I think we're all gonna be disappointed, because we have a wealth of acute care data, but that probably doesn't get to the causes like we're gonna want. So we're gonna have to dig into that and see what we can put together. Now, there's zillions of data in the medical group that has to get processed, because there's millions of encounters. And that should be in our data, but that's, how much they spend to sort of dig into that. That's gonna be where the real.
So what I'm going to do is pick up.
and as we grow with community health worker, programs and those initiatives, it would
see
really be,
myself, and then they could also. And then I'm going to pick up my PowerPoint callers. So what I'm going to do is pick up
we can't even
my
get
camera,
baseline
and I'm just
information.
going
How are
to
we
drag
supposed
it
to
over to
design,
be smaller,
programs that are
and then I'm
really
going to pick up my
addressing
PowerPoint, and I want my PowerPoint to be
So
larger.
I think Minji has come on board and she's been a
So
champion,
now my students can see
just making sure
myself,
she's
and then they can also
navigating
see
all
the
the right
PowerPoint.
tools.
Okay.
And what we
But I want
realized
to see my
is
student,
even the
and
way
then I can drag,
capture
and then
data, we can capture it differently in one department than the other. So that's why we launched the data series
and now
say,
I
hey,
have
we're starting at the baseline ground level,
this one
and over the next 5 years, this is
icon
our
here,
strategic
and then I'll head over to my students, which are here. I will minimize my students there, and then I can go ahead and make this window smaller, and I can drag it over. And now I have my students here. I have my PowerPoint that I'll be.
Rate, and it is not descriptive. It is not descriptive. There's not a discrepancy in the mortality rate. We will have solved many of the issues, if not most of the issues that you're going to be researching. So, as my last meeting, I challenge us to really take a look at that particular piece and start there, and let's work to make a difference, because it's all tied together.
Yeah, everything's all tied together.
So I do have one question there. Where is, like, I know this is getting real granular in a moment, but is there one of those 19 scorecard areas, are there like the help of the restaurant inspections?
Under environmental health.
Environmental health. So,
But it wouldn't have necessarily a specific restaurant.
No, I got you, but you would. You already do that, so I'm mainly just, who gets inspected, how often and when and where, and how many times is there a return trip, and well inspections in parts of the county that don't have access to city water or sewer, and how often those get inspected and when, and that kind of stuff. I think it adds to the equity piece of that, and where it might be different across communities, Midland, Mount Pleasant, Kannapolis, so on and so forth.
Hopefully with the data visualization tool, we can eventually do that. Environmental health is already using a GIS tracking for their on-site water, waste, and sewer. And so Reggie got really excited because she was like, could you imagine if we could really visually see on the map of Cabarrus County who has what? And so we're hoping that we can be able to do that pretty soon.
I love it. Call you when you get that done.
We will.
Coming out of retirement.
I really want to acknowledge Betty and her team. Hopefully you all remember when I put out what the goals were for this year, there were 3 main ones, and one was data and getting the report cards up and running, especially with an equity lens, so we can start looking at our data and make informed, data-driven decisions. And that was a heavy, heavy lift, and she's just doing a spectacular job at getting us in the right direction.
Thanks, Megan. And please review the scorecards, and any suggestions, please let us know, because we are in the infancy stage of them being public. Dr. Daly, you remember we met several times working on the dental data, and so please review them. Our county health ranking, it's a table. We do have a scorecard that will be going live, and we'll also have our scorecard 101 training video that will be uploaded on there too, just in case you get on the site and you're like, what am I looking at? So you'll have that at your fingertips.
Betty, I just want to also thank you for your really good work here. I think that in every organization today, but particularly in these areas that we're dealing with from a public health perspective, having big data available, having rationalized data that makes sense, that's measuring what is meant to measure, can be an enormous assistance in understanding what needs to go next and what doesn't. And Dan, even to your point, I think some of the data coming out of the hospitals and the kind of alignment that can occur within the healthcare community, but beyond that into the community organizations, can be really, really powerful.
And this county is a little bit unique because of, one system is fairly dominant, so it makes it easier because, our data is 85 to 90% of the county's data, which is good. There's a little bit that leaks out. You can maintain that forever, but we like that. But I think in the long run, that if you wanted a place to try to do a nice, facility or hospital system county relationship, this is probably the only one around here you could do it on. Because everything else is pretty split up between, I guess, I don't even know in Gaston how much of that leaks out to Mecklenburg County. I suspect a lot. And not much leaks out of here. If it does, it leaks out to Atria anyway. So it's a good place to do it.
Well, don't worry, I'm coming. But we are working with a regional team too. So we have Mecklenburg, Gaston, Cleveland, I'm missing so many, Iredell, and we're trying to get them where we're at too. So that way, with data sharing, if they submit a report to us, our sister counties know. And so we share borders, so we might as well work together too. We're just waiting on you.
If you care hospitals full, so we can appreciate it. So Laura's new job is helping us keep this well, so it's a good plan.
And I think that's, Betty, I don't want to underestimate the importance of working with the other cities and the other municipalities, because again, to the notion of consistent data, if we're in the lead and I can't imagine, maybe Mecklenburg is doing something along these lines, but I can't imagine anybody else is. And if we can take the lead in supporting that kind of broader regional agreement around data and what's important and how to affect health, then we're going to be really doing something that goes beyond Cabarrus in terms of its value.
And I'm working with them. I'm leading training for those counties to be on one page and understanding what a performance management system is. So hopefully one day we'll get them there. They're at the infancy stage as well. So. All right.
Good pick on the Tableau. That's easier than Power BI.
Oh, yeah. Tableau is definitely easier than Power BI.
I'm not happy we switched.
Okay. All right, so as you all know, for the past 6 months, we've been working on a salary study. That salary study is complete. I can say that in my prior lives, I've always come into an organization at the end of a salary study and not the beginning of one. So this has been very, very interesting. All right, and so we're going to talk just a little bit about the background. I think we all know the background. I was tasked with doing this study when I got here to make sure all our salaries were aligned. I think we did one, I want to say 2016, 2017 Aaron, was the last one, so it was due. It was due to be done again. And we're talking a little bit about methodology and pay practice and all those things, and then wrap up with next steps and recommendations. All right, so the vendor that we used was Gallagher. It used to be Fox Lawson, and they have done a tremendous amount of salary studies. They are They're one of the most reputable agencies you can use. And I say that as I've come in on the tail end of a number of salary studies, Fox Lawson was the company that was used all the time, and then they were actually acquired by Gallagher. What we wanted to do was do an updated market assessment, determine our market competitiveness, and collect market pay practices. So specifically, we wanted to make sure of a few things. We talk about data and equity. We want to make sure we're being equitable in our pay across race, gender, age, length of service, all of those different things. And we wanted to make sure that we were paying people in the right pay brackets, particularly for bilingual staff, for instance. So we wanted to make sure that we were keeping up with current pay practices. So of our custom, so a salary study has two major parts, where we have market data. So the vendor collects market data from or purchases market data from different agencies. That's their job, to collect this market data. So they collect from 3 different agencies. And then you have a custom survey. All right, so these are the agencies that participate in our custom survey. We actually sent out custom surveys to way more than, to a few more than this. And, you know, sometimes you just don't get a response because these studies are generally very long studies and people intend to do them and don't. One group that's not listed is Pitt County. So we actually got data as far away as Pitt County, because Pitt County was doing a salary study. And when they sent their survey to me, I said, okay, well, I'll do yours if you do mine. and that's how that worked out. So Pitt County is not listed here as official, but we did collect data from Pitt County as well. And these are just the ability to collect the market data.
Could you go back to that just for a second? Thanks.
All right, so you have benchmark positions that you use, and these are all the benchmark positions that we use for the study. The reason program manager is highlighted there is because for some reason that has been left off the survey. We're trying to get that data now. I don't know how it was left off or what happened, but it wouldn't move with just 2 positions. I know there's multiple people in those positions, but it wouldn't move those numbers but a few percentage points. So it's not going to skew the data, but I just wanted to make everybody aware that we are missing a couple of positions that we intended to benchmark. And those are additional benchmark positions. So we try to, can you go back for 1 second? So what we tried to do, we tried to make sure that we got as many positions as we could on this survey. We wanted to make sure to get as comprehensive an assessment as possible. So we got really more positions than you normally would get on a survey. That obviously you can't do all positions, so you have to pick the benchmark positions that are most representative of your organization. All right, so market data was available for 93% of the benchmark positions. We did have some outliers, but we used different classifications and statistical tools to get those mismatches out. I would say one of the biggest things, there were very few jobs, but there were a couple of jobs that don't necessarily match to the market or match to anything else. They're kind of CHA specific jobs. And in those cases, well, in all cases, but in those cases particularly, you have to kind of use your best judgment to kind of pick out and parse it out and pick out the things that are most relevant to the position. Of course, there's just more information on the data process, the data adjustment, and the data was aged to July 1st, 2021. So those of you who've been in HR know you have to age the data up a little bit so it keeps up with the market. So you don't just use what you have today, you project out what it should be in the coming months. So and that's one of my recommendations that coming up will be we age the data tables or age the scales every year. All right, so the nuts and bolts of it is if you're plus or minus 5%, you're highly competitive. Plus or minus 10%, you're competitive. Plus or minus 10 to 15%, you're in possible misalignment with the market. And anything plus or minus 15%, you're misaligned. So if you're 15% under, you're underpaid. 15% over is overpaid. And I will say, this is a good news, bad news. It's a good news, bad news situation, because we are really not misaligned like I thought we were. So that's the good news. That's the good news piece of it. The bad news is we had some we had what I feel like is a high number of outliers, but it still didn't move the data too much. So for our peer organizations, our customer survey, we're 8% over in alignment. So plus or minus 10, you're in alignment. The general market, we're actually -9. Now we're a public health agency, so some of the surveys were from hospitals, atrium. So we're definitely going to be under compared to them. But in general, -9% is not bad. And then combined market, we're -3%. So that's really good news. And I probably give Aaron and Sue a lot of credit for that, because Sue with finance and Aaron was responsible for the last survey. So I would give them a lot of credit for making sure that we're just not far out of line in either direction. All right, so, and these are just, I have a few different charts to show where we're aligned with the market. We in general have a 3% annual increase. The average market increase is 2.75, so we're aligned with the market. You can go. Our current structure is misaligned with the market. So our last salary study, it was the current structure from 2016, the last salary study was done in 2017, so we're misaligned with the market. Or 2016, I'm sorry, we're misaligned with the market because 89% of surveyed organizations have updated their salary structure since 2017. Misaligned with the market. Again, with the range progression, we move employees through a fixed range, through a range with fixed amounts based on performance, and so that aligns us with the market. So we are aligned with the market with that. Incentive pay, we don't offer incentive pay. 22% of our organization surveyed do not, so that makes us aligned with the market. Uh, 33% of our organizations do have bilingual pay differential. We do have a bilingual pay differential, so we are aligned with the market on that as well. Next steps, and this is already taking place. We're determining adjustments on salary. There will be no adjustments down, but there are going to be adjustments up. We're going to have to do this in phases, and I'm sorry I didn't put this on the PowerPoint, but we're going to do this in 2, possibly 3 phases. And phase 1 is to look at the low end of the pay scale and hard to fill positions. So specifically, school nurses, dental, particularly dental assistants, and environmental health. So those are our 3 primary focus areas. And there are other little pockets, employees, I wouldn't say pockets, but other individual employees that need to be adjusted that aren't in those brackets or aren't in those areas. So those are our main focus is lower paid employees and hard to fill positions in phase 1. So create a more comprehensive compensation policy. That's part of phase 1 as well. And that'll go to phase 1 and 2. Phase 2 will also focus on employees that are not necessarily low paid, but still underpaid according to the market. And we have to do a comprehensive pay policy to determine people on the higher end. How do you deal with people on the higher end? People that are maxed out of the job grade. So that's one of the things that go into the comprehensive pay policy. To talk about the next thing is regrading. some of these things. You guys, I think everybody's heard me say before, I think we have too many job grades in CHA. We have people with, you know, they're individuals by themselves in a job grade. I'm one of those folks by myself in a job grade. That should not be the case. So we're going to consider the overall salary structure, and we're going to utilize the formal job evaluations and regrade positions. And with the ongoing administration, I've already talked about a lot of this. You know, we're going to adjust the job grade, the salary structure, institute new pay guidelines, administration in the form of comprehensive pay philosophy. We need to do a salary study about every 3 to 5 years. We've already discussed this in leadership about something being ongoing. So every 3 to 5 years, you probably need to do a salary study. And we want to make sure, again, we want to make sure our internal alignment and classification of jobs ensure the proper leveling between jobs. So that's all part of the comprehensive pay policy and the grading of jobs. I think that's it. Any questions? Yes.
Probably more you. I guess. What's the percentage of SWB salary, wage, and benefits of the overall expense for this organization, just as a comparison? I know what hospital systems are supposed to be.
Overall, the fringe and all that, is that what you're talking about?
Yeah, just at high level, what percentage is people and what percentage is everything else? Have you noticed a high level?
It might be a Sue question.
Okay, probably.
I thought you just shared this with me last week,
Is it
that
people-
somewhere around 86, 87%.
Oh, okay.
Yeah, because the hospital systems are closer to, you know, good is in the low 40s, bad is in the 50s, because there's a lot of other overhead. But this is supposed to be a people job.
Right, and it's
Companies.
You're right, it's about 87%.
87% is people, and that's, I mean, I have quite comparators, because, you know, not everybody has all of the clinical services you have, so it's hard to find comparators, so I don't even know what, so that, I mean, that doesn't help me very much. The bottom line here is most of the expense here is people.
Right. Yeah.
That's
And
what
then
I
so,
do.
and then also when you look at it, we're not revenue generators either, so that factors into, we're not really at what demos.
Yeah, well, technically in hospitals, most of the revenue generators aren't people who work either. The doctors frequently don't work for the hospitals.
Right.
And a lot of them, so that's another. Sometimes they do, like Atrium, but in lots of the country, there's not big medical groups that are tied to that business. So I just, that makes sense, because there's not a lot of other expense, probably outside of dental clinics where there's stuff you have to buy.
I really think 87 is too high, we probably need to try to push that down.
Well, it seems like a big number.
That's a
so
big
that's-
number, but we need to push that down a little bit.
Yeah.
Part of what will help is a new pay philosophy, a new structure will help move some of that, number.
Yeah, it just gets tough because you want to pay people at the market, you got to get market level productivity.
Yes.
You end up with the SWB numbers, what it is, once you do all this, usually there's a delta you got to close. I'm assuming you know what that is on the budget.
And then part of it as well is, you know, this is a really good place to work, so people stay here forever. Their salaries do move through the market, so if you've been here for 30 years, and you start out at just an average salary and consistently be a top performer, a good performer, and get raised, it's really easy after 20, 30 years to move to the end of a pay band really quick. So, wasn't 20 years isn't that quick.
Yeah, and again, on those clinical positions you compete with at the hospital, most of them don't have nights and weekends and on-call either, so that's the other piece.
Absolutely. Clinical positions is a big piece of that, but you're absolutely right. All right, so flip to the PDF. So the next thing, I promised the last meeting to come back with the job description. Obviously, I'm not going to read the job description before because I know this was a particular interest to the board. The permanent board, and while Aaron's looking for that, it should be in the packet, but Aaron's looking for that. It's going to be, the position's been restructured a little, so they're going to be a senior admin assistant, particularly working with Dr. Cole, Aaron, me, Sue, and Ryan. We kind of share this person as an admin. They're going to be clerks of the board, and they're going to be the manager for whoever works at the front desk. So those are the three highlights. We're going to post it hopefully tomorrow morning, and hopefully we'll get a lot of, it'll generate some interest and hire, we get a good pool of qualified candidates. But those are the three big things: senior admin to the senior leadership, clerk of the board, and manager of the front desk staff. And we did our due diligence. There is no requirement for any type of certification, and due diligence was done. We talked to the School of Government. Jamie did. Oh, and I need to shout Jamie out on the salary study too. Jamie Newman, the assistant HR director, she did a lot of heavy lifting. That's a lot of heavy lifting with these salary studies. And she did a lot of heavy lifting, so I have to say something about that as well. Any questions about the job description or job duties? Those good. All right. All right, thank you.
Post that tomorrow.
Yeah. Thank you, I appreciate it. Yeah, it will be posted tomorrow, I promise.
Yes.
All right, so I'm gonna give you a quick COVID update because it's good news. So the good news, we can move quickly. So what I've done here, and you'll get this afterwards if you don't have it already, is we've updated your last column to actually have a few more data points. So I wanted you to be able to see a longitudinal look at where we've been. So everything is looking better. Total number of cases coming in on a daily basis, our percent positive, our hospitalizations, our recovery. But what I really want to show you, and I lost the circle in my formatting here, but this 140 people right now are what we consider active cases. We've not been in the 100s. Dr. Buckwell can tell you, because he's our external statistician on any call he can say. Let me tell you the last time we were there. And so, which is amazing. But we've not been in the 100s since last spring. And so we're at 39% of our total population with one dose of vaccine, and we don't have anybody in county provider chapter. Go ahead. So I'm a visual person, so visually you can see here the rise and fall of cases, and man, have we really declined nicely here. Again, you can look back at May of 2020. This graph also shows us where our cases are by age bands, and on a call earlier this week, I said it's kind of nice, those bands are so small you can hardly tell. You know, when you can see the color enough, you can tell we know we've got an issue, but we have 65 new cases the week ending May 22nd. Go ahead. Marcella's done a great job, and we talk about data visualization with Betty, so she's done a great job of helping us understand and show our community who's vaccinated. So the thermometer on the left is actually our 12 and older population now that Pfizer is allowable for teens who are, or almost teens who are 12. And on the right is our total population, even those who aren't eligible. The state's still sharing a lot of data that's all population, so we want to create something that's apples to apples. So if they go to the state website, they're going to see the same thing. So that's why we've got the two here. So, but of those who are eligible in Cabarrus County, 46.5% of people have gotten at least one dose. And what we're seeing are very low percentage of folks not returning for their second dose, which is really good news. Especially once folks started getting that second dose and they felt lousy, we thought, oh man, you know, their friends aren't going to go get their second dose, but luckily a very small percentages don't return. On the right, you can see here some of our regional counties and where they are with a percentage of at least one dose. So, you know, we're right there in the middle to the upper area. And then I wanted to show you, I don't have a slide that's showing our vaccine events in total, but our team continues to work diligently at vaccinating individuals. Even though we're not at the arena anymore, we're not doing 1,200 a day, they're still out there hitting places each and every week. So this week they were at the jail, actually today. Tomorrow we will be here in the evening, so we're hosting some evening hours. On Thursday back at El Puente, which continues to be a great partnership. Friday they'll be here, and then Friday evening El Puente is hosting a community festival in a local mobile home park, and so they've invited us to come and bring vaccine there. So They are working just as hard as they can, and they are getting more invitations to come to places, so their planners are filling up. Go ahead to the next slide. Oh, yes, sure.
I'm gonna show how stupid I am. Somebody asked me this and I couldn't answer the question. I thought I knew the answer. Fully vaccinated are included in partially.
Yes, yes. So the partially vaccinated, those folks who have had at least one dose, then they have to wait the series of weeks to go back. So that partially vaccinated is always, or should always run a bit higher than your fully vaccinated, because they're just not eligible to get that second dose
So,
yet.
again, just to make sure that I'm properly not stupid, partially vaccinated could be called partially and fully vaccinated.
Well, no, they're not fully vaccinated, because we've got, what is that equal to? 5% of the folks who are fully vaccinated or partially vaccinated still have to get their second
I've
vaccine.
had 2 shots.
Right. So you are part of the 41.5%.
What's that? Yeah, no, I know I'm fully vaccinated. Let me ask the question a different way.
Yeah.
Are 88% of the people in the county, that's adding the orange and purple together?
No, so because so if I got vaccinated last week, so I'm in this number, I'm gonna be counted as part of the number on the left. And then once I get my second dose, I'm gonna help drive up the fully vaccinated data point on the right. But no, you can't add them together.
It should say at least partially vaccinated. That 46.5% is at least partially vaccinated.
Okay.
That's where I got wrong.
There's 5% that are partially vaccinated.
Yeah.
Yeah, so at least partially vaccinated is 46.5.
Okay.
Yeah, we can add that.
That makes sense.
So that's the same as saying that 5% are not getting have not gotten their second shots?
Right, because those they may have only gotten the first
Either
shot.
not or not yet. It's just say mostly not yet.
It's mostly not
That's
yet.
the
So that's when you start determining whether people are not showing up their second shots, that's that differential that you're gonna be following to see if they're just,
It could be that, or they may just not be eligible. It may not be their third week or fourth week
That's the
out.
not yet, that's the thing.
Not yet.
When you're calling us fully vaccinated, is that 2 weeks after your second dose, or is that just you had a second dose?
It's 2 weeks after your second dose, yeah. And that would be the J&J as well. So if you have the one shot, you automatically go to the red side.
But if you've had 2 and you're not out 2 weeks, you're in purple.
Yeah, the way they update it.
But still some people have had both, but haven't had their 2 weeks now.
I'd also say that immunogenicity of one dose is probably high enough that that's keeping people out of the hospital.
And what is nice is the way the state built their COVID electronic medical record, if you will, is it allows us to query folks who are far enough out from their second dose so that we can then follow up with them and say, hey, what's going on here? Let's get you in. But again, most folks are proactive in getting it, so which is good news.
Thank you, I feel less stupid.
You were never stupid. So we've updated our mask guidelines here, and so folks who are fully vaccinated and then not vaccinated have some guidance as to our masking expectations. So our folks in our clinical areas are expected to continue wearing the mask because we have individuals seeking services who are not feeling well. For our non-clinical areas, if staff are moving around the building, we ask them to have on a mask, but if they're in a meeting room, having some conversation about if everyone's vaccinated, we can take off our masks. If not, then we stay masked up. Some social distancing, and then just a reminder about if you're quarantined, then, if you are fully vaccinated and you're exposed to someone, you no longer have to quarantine, and that's part of the CDC guidance. On the right here, this was our May 2021 snapshot of where we are with our employee vaccinations. So 65%, again, this is now a couple days old data, but 65% of our employees are fully vaccinated, with another 5% that are waiting on their second dose. We've got 2%, it's kind of hard to see in this visual, but we've got 2% who are really on the fence, they're interested, but they haven't quite made that decision. And then we've got just shy of 28% who at this point in time have declined vaccination.
Have we queried, blindly queried those that have declined as to reasoning?
Yeah, so we've gotten some feedback from folks. Dr. Coyle's done a beautiful job of meeting and discussing with employees some of the questions that they've had. And really it ranges everywhere from, we've got a lot of young women who are still not convinced that there's not a fertility impact. And so it could be that, it could be some people's just overall beliefs in the vaccine being developed quickly. And so it's really kind of been pretty wide range. Anything you want to add there?
Yeah, those are the two that I had folks ask me about the most. And so, we're educating. Our goal as a health department is to hit 80%, both the whole community vaccinated and our employees. But I'm pretty happy that we're at 70% already with our employees. But there's a certain percent that, unfortunately, some people just have their beliefs. I think we shared last month that the state did a study that showed that the two biggest predictors of people having vaccine hesitancy are their political affiliation and a woman of reproductive age.
I will say, it feels like, every week we nudge upwards, slowly, but we're nudging upwards both in the community and locally, or for our employees. So.
I think there's some new articles that I read that are trying to pull that out of that type of discussion to make it a bit. There's actually a new population, I don't know what they're calling it, that not even vaccine hesitancy, but sort of vaccine myth. It's like, I don't know what to call it, but it's like if you're 20 something, you're extremely low risk for severe outcomes. Most of the risks in your families have been vaccinated. It's kind of like, do I have to get off work for the day and go get my shot? It really doesn't matter, and it gets, put in the list with whatever's on Netflix, and whether I got to return to work. And I think there's a fair amount of that that's actually driving it in those populations where people aren't getting it. Because again, it's pretty clear that first of all, the mortality is pretty asymptotic. Once you get above 74, it shoots up. But below that, now that we have a lot more data, it's really flat, really up until about 65, and even that's not very high. So, the youngest person, independent of what's on their voter registration card or whether they're childbearing age, a lot of them it's like, on my list of things that are important, this is like number 55.
Yeah, and the state recently did a study and they came out and said kind of the same thing that, if it's convenient and it's, they can get it when they're, at the concert, then they may do it.
Well, that's why getting a beer, giving it private with a beer is the latest thing.
Yeah, so Cabarrus Brewery, we've been there,
What was the song?
It was actually, it was very well received. Ironically, it was our first community clinic after the Pfizer age dropped to 12. So we didn't purposely have our first one at a brewery for our youth, but we actually had. They did. Go check.
I mean, there's some crazy things that are lotteries, prizes, all kinds of stuff. California's like all over.
You should have made a t-shirt. You should have made a t-shirt that said, "Mom got a beer, I got a shot."
Right.
I love that. You should do that.
I think one of the other things that's going to help encourage those meh folks will be some travel requirements. So, that's the age where folks are eager to get back out and travel. So, a lot of the cruise lines are coming out now saying, well, if you want to cruise with us, you've got to do X, Y, Z, a lot of other countries. So I think, those sorts of black and white card.
Carowinds or Disney for kids to get a vaccine.
There you go.
I've been saying that all along.
So we have an excellent outreach team now. So Erin Babbitt and Maria Trujillo are doing a great job, and they are going out and doing a lot of education sessions and teaching folks and helping people become less hesitant. And so we'll be continuing, 4 to 5 clinics a week. Even though, like I said, it's not 1,000 plus clinics, 50, 60 at a time will get us there. So any questions about
Just one more, and I'm kind of curious, those of you who are docs. One of the arguments that I've heard is, hey, COVID's been around a year, I haven't gotten it, I don't need a shot. Is there any truth to the fact that folks that haven't gotten it may have an enhanced immune system that repels it? Oh,
I don't think so.
No.
Okay.
And they may not have it, they just didn't know.
The poster child for this weekend, John, you all golf, John Rahm, not getting a shot cost him $1.6 million. He's leading the tournament by 5 strokes.
That's right.
And got booted on the last day because he was exposed to turn positive.
Oh,
So,
no.
to me, that should be on everyone's.
Yep.
All right, well, thank you all very, very much. The last slide, there was just a big thank you from our team to the board for the incredible support you guys have given us over the last 16 months now, so really, really appreciate it.
Thank you for your leadership. Thank you.
Okay, our next item will be the health director's report.
So, yeah, in the interest of time, seeing that we're getting to a later hour, I'm going to truncate this down, my report down, to simply saying a number of the things were already mentioned tonight by our various presenters. Everyone's working really hard. I hope you look through it in the packet and contact me if you have any questions about things, but really proud of this staff. They are working hard, and hopefully as the pandemic is winding down, we're gonna be able to get some people off for some very well-needed rest over the summer.
All right, I guess we need to get Sue. She's.
Yeah, okay, the budget.
Yeah.
No, just sort of, you guys pretty close.
Oh, yeah, I'm serving the credit. I just got here, just everybody else.
That's pretty impressive.
That's pretty good.
And 80% either way, either direction. That's all.
Okay, I think next on the agenda are the budget revisions on the consent agenda. You have more this month than you have had in the past.
We'll get Sue.
The budget revisions, so go up.
This one.
No, keep going. Keep going. Keep going.
Motion.
Right there.
All right. Now I want the bookmarks won't work. Come on.
Will you, if you go up to the numbers at the top, or?
Let's try that.
So many you broke it.
I'm broken.
At the very,
You listen?
yes.
There we go.
Keep going up.
I'll promise it to you.
All right, is this it?
Keep going up.
Oh, keep going. You just said, okay.
Keep going. At the very beginning of all of these will be an agenda page.
Sorry, y'all, I tried to do it quick.
Got about 15 more pages.
Oh.
7 pages up there, up back.
That's what I said.
One more. There you go.
Yeah, God, thank you.
Okay, these are the last revisions for this fiscal year. So there's a lot of alignment with budget to actuals. This year, a lot of our staff, there were lapses in salaries due to positions not being filled or folks being pulled due to the COVID. So we were able to shift some of those funds around. Does the board have any questions about the budget revisions on the consent?
Okay, if there's no questions, may I get a motion to accept the budget revisions? Okay, Dan, thank you for it. Can I get a second? Thank you, Ship, very much. All in favor? Aye, thank you very much. All right, so you may continue.
Okay, we are going to do a quick overview of the 2020 to budget. It was presented in May. The two differences in the budget from the one that was presented in May. Steve, if you can keep going down.
Keep going.
Again, yes. WIC, I'll keep talking, I'll do this stuff.
All right.
WIC was awarded more money than originally anticipated, so their budget went up, and we were able to put in the dental budget some additional equipment that they need to purchase next year, as well as some additional Medicaid revenues that they are anticipating. So those are the two biggest different, or really only differences between what was presented in May and what is presented in June. Yes. So this first few pages is the budget ordinance that's signed by Dr. Coyle and the board chair. And then you have your budget message as well as your budget. At the end of the budget document is our fee schedule for dental clinical services, as well as a few of the program summaries that you can read at your leisure anytime. So are there any questions about the final budget for this fiscal year?
Okay. Before we do that, I do have to open up the floor for a meeting from the public for any comments, which again, the budget has been out and available for the public to review. So at this point in time, I do open the floor for any comments from the public concerning the budget for fiscal year 2022. Okay. Hearing none, I now close the floor for that. And again, I would like to have a motion that we adopt the fiscal year budget for 2022. Okay, Dan first, and Annie second. Chris, Chip second, and again, all in favor? Thank you very much. Motion carried.
Thank you.
Thank you, Sue.
Sue, before you run away, I don't know if I can take more time on this. I'm used to an organization where you budget, and that budget is hard and fast for the year. And variances occur, and you manage the variances, and you concern yourself about those kinds of things. I understand that we're in a different world here, but I kind of itch to know that information and know how we're handling it.
The budget revisions are kind of how we true up what we're originally projecting to what the variances are. We look at those variances each month to determine if it's lapse in salary, increase in our services, or a decrease need for our services, additional grants that we may get in, or additional funding that the state pulls down. So those are the majority of what we see as variances. If in clinical services, if there's an increase in pediatrics, then we'll see that through, but we do adjust for those.
What I'm saying is, so I've got a group of people over at campus that are business development people, and they have a goal, I'm gonna make this up, of $100,000 a month. And when it comes in at 90,000, I get a big smile on my face, because I get to beat them up about the 10,000 that's missing. And we need to talk about that 10,000 because they're short where they should be. On the other hand, sometimes they come in at 110, and then I don't get to smile because I don't get to beat them up. That's the part that I don't. Maybe I'm showing my.
It's cost versus accrual. Okay, I'm sorry. Yeah, it's just took me 10 years. Well, I won't say that long. When I was running practices, I understood this. You come to the big systems, you do accrual accounting. You have to go to 10 years for the classes to understand. Once it's in your head, it's hard to go back to cost accounting. I just think problem. I look at it and I have to think back. Okay, when I get my practices, is how we did books.
Yeah.
But it's really hard to translate cost back to accrual because it isn't the same.
Yeah.
You're the expert. That's really, I think, what's happening here.
So to your point though, then, and I get that at some level, it's hard for me to translate.
Yeah.
because I think of it in the P&L sense.
Yes.
But more important than whether or not we meet our budget or don't, in a setting where I'm focused on making money, if you will, is the fact that those numbers say to me, there's a problem here, or there's not. And that's the part that maybe I'm missing it, but I don't get visibility.
Yeah, it's tough.
Yeah, I get it, because for the past 20 years, that's what we justified variances,
Right.
you know, that kind of thing. And so this has been an adjustment for me to get.
Yeah, the budget's fixed in accrual accounting and cost accounting, both sides fluctuate.
And I don't have a problem with the fact, obviously we're doing it the right way, we're getting good marks on our audits and everything else. The question is that other piece available that tells me that we plan to spend this amount and we actually spent this amount and there's an issue there that we need to look at?
Isn't that in the green button, red
That's what I
button,
look
yellow
at,
button?
That's what I was saying.
Yeah.
And that's where I would get it from there. I get it from there because I understand this type of accounting because it's what we have to do in schools to meet the legislative requirements. And I'm sure there's a legislative requirement that creates this type of accounting for health agencies. But in the green, yellow, and red, and it's on page 41 on the one I got anyway, so that's where I say, okay, we're in green, we're in green, we're in green, we're in green, we're in yellow, yes, mental health, yes, I realize we were out because of COVID, we couldn't meet face to face, but we went from red to yellow.
Yeah.
So we're getting better.
That's the only thing that's not been green, and you've been watching the revenues catch up because the expenses are flat because there's not patients. So, I mean, that's what I watch as the trend, but it's just, I mean, that's the advantage once you learn it to roll. And believe me, it's hard to go from one to the other because I remember going to a zillion classes. They don't have an MBA trying to work what the heck the hospital was talking about. My practice when I took my first administrative job, because that's greed when you come out of balancing your books every month, because you gotta make payroll, right?
There's a couple of things that we look at. The assistant finance officer and I break up the departments or programs, and we meet with them, depending on the program manager and the complexity of their budget, either monthly, bi-monthly, or twice a year, semi-annually. Depends. We are beginning to take some budgetary stuff to leadership, at least once a month, sometimes twice a month, breaking down the programs, and we'll continue to work through that next year. And the revisions are a great place to see that, and part of our audit is how much within budget are we? We cannot be over budget within certain departments, or we will get audit findings and exceptions. So you will see that there, but I'm welcome to work on any reports, I would like to see that.
The one thing that I did, and Chip, I was trying to find the bubble chart here, so thank you for telling me where it was. And because that was my answer, my sense of what the answer to my question was. When you were going over that earlier, the thought that occurred to me is that it would be, for my purposes, being the P&L type that I am, it would be really interesting to see if it's possible, not only the budget and actual this month, but maybe the last 2 months to see where progress is either not being made or being made toward what the budget is and where we're going. Does that make sense at all? Sort of, that would be, for me, would be really helpful to see progress.
So you'd rather have the numbers, the specific numbers, rather than the shade of green or yellow?
No, I like the fact that I don't have to look at certain things, because I know if the green is good. That tells me everything I need to know.
Even in the column where it's the green dot, if you had 3 green dots for the last 3 months, a green dot, a yellow dot, a green dot, a red dot, a yellow dot, a green dot, if you dotted those things, it would give you a visual representation of, so we're getting better or we're getting worse, and where are we? And then you wouldn't have to deal with all the numbers across the board, you just deal with the 3 dots in the middle or whatever.
But even up arrows, down arrows, flat, you could do something like that. So you know if you're agreeing, because you agreed on everything, so I never really dug into the numbers. But there's a little bit of faith you have to accept when you're used to looking at, looking at a P&L. I mean, that's just.
Right, and certainly, from a P&L perspective, I want to see the trend.
Right.
I want to see.
That's why maybe 3 months of up, down, flat arrows maybe be another way to do it. I think the color thing's really easy to look at.
Yeah, it is. Thank you.
Just more stuff to do. You get another star, you get another star in your awards.
Okay, the only item left on the agenda now will be the informal public comments from the floor, which again, I don't see any, hear any. The only other announcement that I had, again, we appreciate you and all the work that you've done, and like I said again, we're gonna really miss you, so, enjoy your retirement, I guess we'll say that to you. The other, we don't have a board meeting in July, which we normally don't schedule one, so again, our next meeting will be on August the 10th, and we should have the new board members with us at that point in time to be sworn in, as well as the elections or new members, I guess, as far as chairman and co-chairman at that point in time. So if there are no other questions and no other information, I will need a motion to adjourn our meeting.
So moved.
Okay, thank you very much, Mark. And may I get a second? Second. Thank you very much, Ms. Dr. Taylor. And again, all in favor? Thank you very much. And our meeting will be adjourned again. Thank each of you very much. Enjoy your July. Be safe, be careful of whatever you're going to be doing next. And just